Welcome to the Bigger Picture of the Targeted Assessment for Prevention conference call. My name is Adrienne, and I'll be your operator for today's call. At this time, all participants are in listen-only mode. Later, we'll conduct a question-and-answer session. I'll now turn the call over to Kim McCoy. Kim McCoy, you may begin.
Great, thank you, and good afternoon, everyone, and welcome to today's webinar. This is the Bigger Picture of the Targeted Assessment for Prevention, brought to you by the Lake Superior Quality Innovation Network, or LSQIN. Lake Superior QIN is composed of three organizations: MPRO in Michigan, Stratis Health in Minnesota, and MetaStar in Wisconsin, in support of the Centers for Medicare and Medicaid Services Priorities for Healthcare Quality Improvement. We know that all of you, all healthcare organizations, are working hard on making quality improvements in your facility in order to prevent and reduce HAIs, hospital-associated infections, and to support a culture of safety and improve communication. We hope that what you learned today will help all of you to be more successful in those efforts. The session today is being recorded and will be available in about 2 weeks. The PowerPoint handout is available on the initial login screen on the left-hand side in the section titled Event Materials. If you enter the password TAP, T-A-P, into this section, you can access the document. In addition, we've also posted a link to the slides in the chat function of the webinar today, so you should be able to pull it from there. And we'll remind you again about how to access the slides and the recording at the end of the session. All lines will be muted during the webinar. We're hopeful to have a question and answer session at the end, so please make a note of any questions that may come up as you listen, and we'll respond promptly at the end. You can also feel free to post those questions in the Q&A function of the webinar. Just know that we won't respond to them until we get to the end of the presentation. And again, so that we know you're fully present and engaged in the session and paying attention, please feel free to share your thoughts in the chat function as we go. And with that, we'll start today's presentation. Our first speaker will be Michelle Nordwall. So Michelle, I'll turn it over to you.
Thanks, Kim. Hello, everyone. We hope that following today's webinar, you will have the information you need to not only run TAP reports from NHSN, but also be able to describe the information in the report to others on your team. You should have received an email from your Healthcare Associated Infection Lead within the past 2 days requesting you run the NHSN CAUTI TAP report using the cheat sheet that you were provided. It is also our hope by the end of this presentation that you'll be able to take your own data and analyze it to determine if interventions have been effective or if they need to be revised. And sorry, I forgot to, that was the slide, sorry about that. So we're going to go on to the next slide. And we're going to start out with a polling question. So Jennifer, if you could bring up that polling question. So what is your current comfort level with running, explaining, and understanding how to use TAP reports? 1, we have no experience. 2, we run the TAP reports but have not used the data outside of the infection preventionist. 3, we run the TAP reports and share the data with our reduction team. 4, we run the TAP report, share the data with our reduction team, and plan improvement based upon the data in the reports. So if everyone could please mark your selections now, and then we'll give you time to respond. In the meantime, I just wanted to mention that back in 2005, September of 2015, we asked the LSQIN participants to complete a facility needs assessment, and we asked if they were using TAP reports. At that time, we found that 38% were using them in Michigan, 11% were using them in Wisconsin, and 9% were using them in Minnesota. In a recent TAP poll conducted during a national APEC webinar, participants indicated 28% were using TAP reports. Based upon this information, we felt this educational session would provide a better understanding of the TAP reports, as our goal is that 100% of our partners are using the TAP strategy. Keep in mind that the TAP strategy has 3 steps. The first step is target. Select which aspect of HAI reduction you want to focus on, such as CAUTI. After today's presentation, you will be able to determine which units have excess HAI. Second step is assess. This can stand for the assessment of the data in the TAP report, but can also be the TAP assessment tools you may have used to determine your gaps in your current CAUTI or CDI projects. The last step is prevent. After knowing where your excess infections are occurring, knowing your gaps, you can then address with resources. Your LSQIN HAI lead is always available to provide or locate possible solutions. So now let's look at the results of our poll. Since it's ended, it's looking like, I know we have about half of them didn't answer, but of those that answered, the 7 have said they have no experience, and then it's kind of heavy on the no experience, but we do have 4 saying that they've run them, shared them, and used the data. So I think this seems typical of what we've already been hearing in our original assessments in the APEC one. Trying to click to the next slide. Okay, so the TAP strategy is a data-driven approach that utilizes the data that your facility enters into NHSN. The data is used to prioritize healthcare facilities and specific units within facilities with a disproportionate burden of HAIs so that gaps in infection prevention locations can be addressed. The benefits of TAP strategy include a focused approach to prevention. Rather than doing everything possible, you can focus your attention on what is most needed. Excess HAI are mapped out for CAUTI and CLABSI. By knowing which units are driving your higher rates, you can monitor the impact of your prevention efforts. The CAD is a concrete prevention goal linked to the SIR, and we'll be talking more about that in just a moment. Then there's specific gaps in infection prevention can be identified through a standardized assessment of targeted units. Using a TAP tool, you can determine which best practices may need to be implemented, monitored, or modified for your facility needs. Allow you to focus your strategies to address your gaps. All hospitals are not alike, thus each hospital will need to develop their own strategy for improvement. Before we get into how to run the TAP reports, let's start out with a basic understanding of the TAP reports and some important definitions. The TAP report provides the number of infections that need to be prevented in your location or unit to reach a specific target. This is called the cumulative attributive difference, or CAD. The report ranks healthcare facilities and patient care locations within these facilities by the CAD in descending order. These reports also contain other applicable information for prevention of HAIs, such as the count of HAIs, the standardized infection ratio, the device utilization rate, and pathogen distributions. To be clear, the single facility TAP report provides data, so if you're running it for your single facility, that report provides data at the unit level, so units within your facility, that are reporting their data to NHSN, and then the units are ranked by the CAD. And you can run TAP reports for CLABSI, CAUTI, or CDI. If you're part of a hospital system, which you have a group of hospitals, you can also run a TAP report to find the ranking of the hospitals in your group compared to each other. And additional information can be found on NHSN's website in their group users how-to guide, if you're interested in that. Now I'll go over some basic definitions for some of the information you will find on the TAP report, including SIR, CAD, and DIR. The standardized infection ratio, or SIR, is the ratio of observed infections divided by the predicted infections for a facility in the designated time period. The SIR adjusts for patients of varying risk within each facility. SIR can be compared across facilities as the risk has been stratified. The predicted number of events for CLABSI and CAUTI is calculated for each patient care location or unit by taking the number of device days and multiplying it by the NHSN pooled mean divided by 1,000. So that's how they calculate it for CLABSI and CAUTI. For CDI, the predicted number comes from the risk-adjusted models. Since the SIR is calculated by dividing the number of observed infections by the number of predicted infections, then if you have exactly the same number of infections as was predicted, then your SIR is going to be exactly 1. If you have more infections than predicted, your SIR will be greater than 1. If you have fewer infections than predicted, you would have a SIR less than 1. The Health and Human Services, HHS, 2013 National Prevention Target identified the reduction of HAIs as an agency priority goal and is committed to reducing the national rate of HAIs. HAS set a CLABSI target SIR of 0.50, a CAUTI target SIR of 0.75, and a CDI target SIR of 0.70 for 2013. NHSN has suggested for 2015 a CAUTI data target SIR of 0.55, so instead of that 0.75. When available, HHS will use 2015 baseline data to propose new 2020 targets. Also, CDC will use 2015 data for new baselines for all HAI measures to be implemented in the late 2016 or early 2017. You may have also heard this called rebaselining. The device utilization ratio, or DIR, is a measure of device use on a given HAI shown as a percent. This can be calculated by dividing the number of device days by the number of patient days. So for CAUTI, it's the number of catheter days divided by the number of patient days. There's also something called the national pooled mean. This is the national average device use that you want to be below for your particular unit. This is calculated in January of every year. So this way you can compare your neurology ICU to other neuro ICUs to see if your facility is keeping devices in longer than similar units across the nation. Unfortunately, when you run the TAP report, this national pooled mean is not on the report. So you would actually need to run a CAUTI rate report to find that national pooled mean. But that CAUTI rate report also has your your national pool or your DUR right next to it. So that CAUTI rate report is another important report you can run. At the end of this presentation, DeAnn will share a tool you can use to help use to run this report as well. Now with the CAD. The CAD helps you know where to focus. And I'm waiting for this slide to switch. There you go. The CAD helps you know where to focus. In conjunction with the SIR, the CAD can be used to identify and prioritize locations for targeting HAI prevention efforts. The CAD translates a target SIR into a numeric HAI prevention goal, providing a concrete goal to drive action. So you will be able to make a statement such as, in order to achieve a target SIR of X, whatever your goal is, maybe it's the HAS goals, I need to have N fewer infections. So it's actually able to come out with a concrete goal. And then the CAD can identify units with excess HAI burden that might otherwise be overlooked. The CAD is used as a prioritization metric to identify the facilities and units with the highest burden of excess infection. Targeting these locations will yield the largest impact on HAI prevention. But because the CAD is not adjusted by risk exposure size, it should not be used as a metric to compare performance of units or facilities. So, for example, a larger unit with many urinary catheter days will likely have a higher CAD than a smaller unit. So you just want to be careful with those kinds of things. So, but a positive CAD means more infections than predicted or excess, and a negative CAD means fewer infections than predicted. Our next speaker will be Yongmei Quinn, who will explain how to run a TAP report.
Thank you, Michelle.
If you have not had the opportunity to do this as well, at this step as well as interpret the data, and then I'm going to pass the ball over so she can do slides. Thanks, Yongmei.
Thank you, Michelle. Yeah. Good afternoon, everyone. TAP reports can be generated within NHSN for Class C CAUTI and CDI Lab ID data. As a reminder, facility locations are ranked by the cumulative attributable difference, which is CAD. TAP reports can help to prioritize the locations where the greatest prevention impact could be achieved, or monitor the impact of your improvement efforts. Our example will demonstrate how a facility can generate a TAP report for CAUTI data within NHSN. After opening and signing into NHSN, click Analysis. On the Analysis choices, select Output options. On the Output option screen, expand the TAP Reports folder to select the facility type to see the available TAP report options, as the TAP reports are organized by facility type. Today we are going to select acute care hospitals. Next, select CDC-defined output, and then after you decide if you are running a Class C CAUTI or CDI report, you can either run or modify. We recommend you click Modify to create a custom TAP report which can be saved so you can run it again in the future. Just be sure to save the report with a different output title than what is automatically assigned. For example, we may want to type the word CAUTI instead of using the default CAU used by NHSN. Select output format as HTML, PDF, CSV, and RTF are all options. We are going to use HTML for our example. Include variable labels for more descriptive column headers by clicking the box. This will make it easier to read the report. Limit the TAP report by time period. In our example, we are running first, second, and third quarter of 2015, but you can determine your own time period such as year or just one quarter. Choose the source value of the CAD multiplier, which represents a circle or target. It can be a custom value, or the user can choose the HS goal or the CADI national SIR. These are available in the source drop-down menu. The default source is HHS goal. For CLAPSI, the HHS goal is 0.5, for CADI is 0.75, and for CDI is 0.70. If a custom value is used, remember that the multiplier must be less than 1. In our CADI example, we use the NHSN recommend custom value 0.55. Remember to click Save As before you run your report. This way, it will appear in Custom Output section of the Analysis Output option, and you will only need to modify your time period for your next report run. Finally, click Run to receive your report. This is a test facility, and it does not reflect the real data, as it's just for example purposes. Let me walk you through the information in this report. After org ID, which is your NHSN number, your facility name is listed, and then your overall cumulative attributive difference, or CAD, as we previously discussed the CAD. In today's example, the number is positive, thus this facility CAD is 8.17, which represents approximately 9 excess infections, as we need to round up. Take a moment now to look at your own report to determine which group your overall facility CAD falls into. Remember, a positive CAD reflects excess infectional events. A negative CAD reflects fewer infections than predicted. The units are ranked by highest CAD, which has the greatest potential to improve, to the lowest CAD. Please note, it is not sorted by the SIR. We can find this in the location rank column. The units at the top have the greatest needs to reduce infection. In our example, the ICU location is ranked as number 1 location rank. This means that this location has the highest number of excess CADI infections than all other locations. Coming in second is the rehab unit. Take a moment now to look at your own facility report and determine which units need the most attention. Still looking at the ICU, this unit had 5 CADIs or 5 events identified in the time period specified, while the rehab unit had 2. Take a peek right now to note your infections for each of your top units. In this ICU unit, there was 400 urinary catheter days during this time period compared to only 50 in the rehab unit. The next column will provide the device utilization ratio, which is stored as a percent. In this example, it was 32%. In other words, 32% of the patient days in this unit were also urinary catheter days. The rehab example was at 25%. Again, take some time to look at your door on your own report for top units. The CAD in the ICU was 4.31, indicating that at least 5 infections would need to be prevented in order to meet your facility reduction goal, compared to 2 infections in the rehab unit. On your own report, round up and indicate how many less infections you would need to reach your goal. In this example, the standardized infection ratio, SIR, is not calculated as the number of predicted events is less than 1. On your own report, you may have a SIR listed as well as an indication if the SIR test is significant. I'm now going to hand off the presentation to DeAnn for additional items you should also review in your TAP reports. Thank you.
Thank you, Yongmei. In the next part of it, we're going to look at the number of pathogens reported in order for all the events that are reported. This number may be greater than the total events, as multiple pathogens can be reported per event. The next number indicates how many E. coli, listed as EC, yeast, both Canada and non-Canada species are listed as YS. Pseudomonas aeruginosa is listed as PA. Klebsiella pneumoniae or Klebsiella acetosa is listed as KS. Proteus moralis is listed as PM. And finally, Enterococcus species is listed as ES, where in these events. By looking at these pathogens, it can help identify potential areas for improvement. I'm going to have you take a moment right now just to look at your pathogens and see how they're driving your infections for your TAP units. I always encourage hospitals to really validate your units and how they're showing up in the report, as well as how your units are mapped. So when you're looking at the CDC location, make sure it actually accurately reflects what your location is. This really does have an impact on your rates as well as your DUR comparison for the means. All the units are entered data into your NHSN should be reported. If they're not listed on your report, go back to your monthly report plan as well and verify all your information's been entered, because this will impact your facility CAD. Also, as I mentioned earlier, validate your units are mapped correctly in the CDC location selection of the report. In order to compare those apples to apples, this location descriptions must be accurate. We encourage you to review this annually. Anytime unit names change, patient population changes to what unit they're going to. I'm hoping that you still have your reader glasses or your cheater glasses with you, because it's a good time to look at additional information. Habits can be good or bad, but we want to support the habit of reviewing your header information. Always verify you have the correct time period. That time period for the data being pulled is listed as the top, as well as when the data was pulled. Be consistent with your CAD multiplier. I can't stress this one enough. If you change that multiplier, you will change the results of your report. So make a decision and document your standard. It doesn't hurt to document why that particular modifier is chosen. Just know that if you want an 80% reduction in events, you can indeed list your custom multipliers 0.2 for that 80% reduction. The HHS goal is automatically selected, so you can always, if that's your decision, know that it will automatically be selected. But if not, make sure that you choose the modifier chosen by your organization or your infection prevention group. Also, it's good to get in the habit of looking at your footer, as it will consistently list how the calculations are made. This is a great resource when you're using this in a committee or a discussion and somebody asks how something's calculated. Use it as your cheat sheet because you can use this as a resource and share how the calculations were actually made within your TAP report. Next, look at your whole report. I love to look for those positive deviants, and that is where units are at the end of the report. So these are your top performing units. Positive deviance is a behavior change approach that's based on the observation that in any community, and in this situation a unit, there exist individuals who have found uncommon practices and behaviors that enable them to achieve better results than their peers, despite similarities in problems and available resources. This is a great time to go to those units and start asking questions of that frontline staff of how do they make these things happen and how do they prevent infections. You may find that that unit has something unique that they have done or implemented, or may have a key individual who's been your champion and you didn't even know it existed. That way you can try to replicate and utilize that. Just know that sometimes what you find in one unit may actually create more work for you. But I don't want to say that in a negative way. If you find out that they're pulling multiple different items to actually insert a urinary catheter, it's a good time to go back and have that discussion of do we create one Foley kit for insertion rather than pulling multiple. But you may have to take care of some things that you didn't expect to find. But again, I always go back to the benefit is for the patient, and that's why we're here in infection prevention. Know that you can run additional reports. Smaller hospitals may wish to run a single-line list, which is inclusive of all the HAIs identified. Frequency tables allow you to obtain counts of records meeting certain criteria and can also perform chi-square analysis for statistical comparison, such as how many CAUTIs were reported as SUI. Also, rate tables display your facility's calculated rates and device utilization ratios. If you're able, you can provide the provided NHSN published sorry about that, let me start that word again there. If able, you can use the NHSN published pooled means and comparison of your facility rates and ratios through that report. Now let's take a look at resources. Our first resource actually comes from the Tennessee Department of Health HAI Prevention Calculator, and it's provided by the Tennessee Department of Health HAI program to assist healthcare facilities in prioritizing HAI prevention activities. To use it, the first thing you do is to determine a time period and the HAI of interest. So that could be a quarter, it could be a calendar year. You can select from the HAI from the drop-down menu or choose a custom target and enter the target served. 3, using the CDC's National Healthcare Safety Network, you obtain the number of infections for the time period of interest and the number of predicted infections, or the standardized infection ratio for that time period of interest. 4, you entered all that data into the form, and 5, you click compute, and it will automatically determine how many HAIs would need to have been prevented in order to reach the target SIR to be reached for that time period of interest. And you'll notice that the location is right in the header for you so that you can access that report. At this little time, I'm going to take a little road trip. As mentioned by both Yongmei and Michelle, we do have things on our website, and you can see at the header of this slide, it tells you where you can reach our website. And I'm going to go there right now. So on this, you will find it brings you to our home page. Under initiatives, you can highlight there, and I would want you to go down here to the hospital healthcare associated infections, or the hands rubbing together near the water. And it's taking a moment to get there. Once you're there, you're going to notice under new resources. So one of the items we mentioned is that DUR. Looking at your units, what percentage or what calculation is using indwelling urinary catheters versus the national pooled means. I would encourage every single one of you to actually open up this resource so that you can actually see how to actually run that report and how to look at yours versus the national. Even though some facilities may not have any infections, I still encourage you to utilize this because our number one way to prevent a catheter-associated urinary tract infection is not to have the catheter. And the best way to see, are you within a range or are you within norm, is to run that report. Because if you're finding that you're utilizing, let's say, 0.75 in your ICU, but the national pooled mean is 0.54, that gives you an indicator that you need to go back and look at that unit and see, are they following your facility standards for when it's appropriate to use that catheter. Also, on our resource page, you're going to find new resources. This comes actually from the Ann Arbor, Michigan. It was printed back in May. They did a wonderful job of looking at all the different studies and all the different ways of looking at what's appropriate and not appropriate to use an indwelling catheter. You will find the summary of the most common uses for the urinary catheter there. This gives you an overall summary of the information that was shared in that report. So you'll be able to see a comparison of the clinical indication as well as if it's appropriate for indwelling, a straight cath, external, and some non-catheter options. So you can see that it provides a nice, compact information that's included within that. But in addition, we also did break out by the specific types of catheters. So if you would like to see when it's appropriate to use an indwelling urinary catheter for hospitalized medical patients, it actually goes through and gives you the different indications as well as additional notes that you may want to be aware of. So again, some great resources for you to utilize in your prevention and reduction program. And as in previous, I do want to highlight that we still do have the CDI and CLABSI TAP tool report, and that's how you actually can run these reports more specific to what your project is so that you can use those as a way to help run those. I'm going to go right back into our presentation. The other items that you will notice, such as on the CDC, it does provide the most recent national data, including numbers of hospitals participating, the types of units, the pooled mean rates, and device utilization. Although our most recent report, and I'm sorry, I'm going to flip to the slide I'm actually reading, that it does include 2013 data, we do expect this to be revised in 2016, but it's unknown exactly which month this will be. So at this time, we really don't expect it before August. On this section, you will notice that it includes the National and State HAI Progress Report, which is based off 2014 data. This way you can see if your state's improving, staying the same, or it has had increased infections. On the previous page that I had skipped over, I did want to highlight that CDC does have their TAP resources, and you're welcome to use those. And we left the website location at the top, so if you would like to, you can go ahead and find that. So again, if you are a group user, let's say you're part of a large healthcare system and you would like to compare your different locations, you will find that how-to guide for user group within that. In addition, the Wisconsin Department of Health provides HAI tutorials related to NHSN at their website, and Ashley was kind enough to say, absolutely go ahead and share this resource across your region. Just know you can click on any one of those topics related to facility setup, specific events, as well as analysis, and Ashley continues to add those as she gives those presentations. So thank you, Ashley, for allowing us to share that. So in summary, we're hoping that we have you leaving this webinar feeling like, yes, indeed, you can run that TAP report. You can use the data to lead your reduction team efforts and determine if your current interventions are effective or if they need to be revised. Jennifer, can you go ahead and release the poll question for me? let's end with this polling question. Based on what you learned today, what's your comfort level with polling and interpreting your TAP reports? So you either got a, I got this, or I'm still working through it, but at least it makes sense. Or how about I'm still working through it, but I still may need help every once in a while, and that is just fine. That's what we're here for as a QIO, is to help you through that. And 4 is, I have to do what? So please go ahead and make your selection. And in the meantime, while we're waiting for those poll results to come up, Adrian, do you mind if you could share with the participants how they can ask a question?
Thank you. We'll now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There'll be a delay before the first question is announced. If you're using speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. And we do have a question from Carol Bass. Please go ahead.
Hi, Carol. How are you doing today?
I'm good. I just want you to go through that CAD multiplier one more time. You gave us for CLAB to use 0.5, for CLAUDI to use 0.55, and CDI to use 0.7. And I just didn't quite understand where those numbers came from. Those are national numbers?
Those are national numbers, so they come from HHS, and that was written into, I want to say it's the 2013, or it's actually the goals they had for us to reach in 2013, and they kept those same goals at this point in time.
Okay, thank you.
And Carol, I can send you that direct link to that document if you would like.
Okay.
And as a reminder, if you have a question, please press star, then 1. And we have Katie online with a question. Please go ahead.
I was just wondering if you could send me that same link as well.
I sure can. What I may do is I'll send that link to all of your task leads for each state and have them send out to that link to all participants on the line today.
Great. Thank you so much.
You are welcome.
And standing by for more questions. As a reminder, if you have a question or comment, please press star, then 1.
And while we're waiting for more questions to come across, I did want to share on the poll, at least we did have a nice shift that we're up to 14% that really feel that they got this and can move ahead, as well as 8 feeling that it does make sense, or 19%. 7 are still working through, but may need a little help, and again, that's what we're here for, and only 1 individual, and whoever that 1 individual is, I hope that you do reach out to your task lead so that we can help you, because we really want to make sure you're comfortable with this information.
And at this time, we still have no questions in the queue. As a reminder, if you have a question, please press star 1.
DeAnn?
Yes.
Can you hear me? Yeah, we have one question in the Q&A from Denise Tracy. She asks, can you please review how to obtain the DUR again, the DUI?
Absolutely. And what I'm going to do, Tracy, is I'm going to go back to the website that we have. So I'm going to actually share my screen one more time. And what I'm going to do is actually open that document up right underneath New Resources, the Re-Energizing Clotting Reduction for Step-In Reduction. And I'm going to make it a little bit smaller so it's not as big. It actually is going to walk you through exactly how to run that report. So much like Yongmei had said, log into your NHSN and on your left side, click Analysis. We're also going to go to the Output options. But instead, we're going to click the Device Associated module. And within that, we're going to click the Urinary Catheter Associated UTI. And under that, we're going to click for next step, the CDC-defined output, and finally the rate table for CLAUDI data for ICU, other, SCA, and ONC, and then click Modify. Once you have that, much like Yongmei said, if you're saving that report, actually give that report a name that makes sense to you, that's going to help you remember what it is. I always like to encourage all IPs or individuals using NHSN to always click that variable label. That gives you more information when you run your report and makes it a little more understandable. Also, in the same way, I also always click the box talking about the data variables and time periods at the time. Again, it just gives you more information in your report and makes it a little bit easier to read. Entering that time period that you wish to use for comparison. And the group by, you can actually leave that blank. And once again, if you want to save that report, go ahead and hit Save As so that it will appear in your custom output. Again, you can then just go right to your custom output and run this report for the future. But what you will receive within the report is it will actually show you if your CAS DUR is greater than the CAS means. So you're going to see with this first blue arrow pointing down, that CAS DU is actually your unit's CAS DU. So in this example, I'm trying to see beyond the red circle, but I believe that that is 0.92. That next column is the CAS DU mean. So that's the national mean. So that's what you're going to compare it against. So you're comparing against nationally for that same type of unit, and that's why I go back to the mapping within NHSN, and that's why you have to always validate your mapping's correct. For a same unit, that nationally they're seeing the mean as 0.65. So when I look at the ones that I can see more clearly, you will see that I put stars next to those that were higher than the CAS means. So if I ran this report, I would know that I need to look a little bit further. So it looks like this is the BICU that in this one example is in December of 2005 that I exceeded what I had hoped to reach for the CAS DU means. And when you run this on your current report, you will see again all the units that you're following for CAUTI, and you'll be able to see exactly what the CAS DU mean nationally is compared to what you actually have on your report. And this is a great way to start your reduction as well as with your TAP report, because your TAP report will tell you what units have the most excessive infections. This report will tell you what units are using catheters more often or less often compared to the national. And we know as infection preventionists, the best way for us to avoid a catheter-associated urinary infection is not to have the catheter in. I like to stress that even if your SIRS and your pads are all below, I always go back to it's the patient. If that patient was your mother, father, grandmother, grandparent, or loved one, would you want them to have the catheter in place just because? And that's how I always encourage staff to look at it, that if you put yourself into that place, yes, the catheter has great conveniences and it is needed for medical purposes, absolutely. But it is also a risk to the patient that they may develop an infection. And our whole purpose behind what we do in infection prevention is to prevent the infection. So this is one way I'd really encourage you to go back, run this report so that you can actually see exactly where you're at compared to the national. And that way you can bring it back to your work groups, your committees, and have a discussion of what can we do next based on our TAP, based upon the DUR report. What can we do to lower those infections?
And
I'm looking also at the Q&A. And Amy, you're asking if the CDI Lab ID TAP report, if there's different instructions for getting it. Yes, it's on that same website that I just showed you with the LSQN in the HAI reduction. You'll actually find one for CDI right there. Please know that when you run your CDI report, unlike the CAUTI reports, which it will list out each individual unit, it will only give you one number to look at because it's house-wide with that. But it will still give you an indication of where you're following within your CAD. Adrian, do we have any other questions on the line?
We have no questions in the queue, but if you have a question, please press star then 1. And we have Deborah White online with a question. Please go ahead.
Yes, good afternoon.
Hi, Deborah.
Hi, I'm really enjoying this information that I'm getting from the CAD, but I noticed that when I'm running various reports according to different time frames, the units at my facility that show up on top continually changes, almost too quick for me to be able to say I'm having an impact. In other words, back in December when I first learned about TAP reports, I had my target units, so I bought. But the next couple quarters, they weren't the areas that were having issues anymore. It was other units. So I'm wondering if you have any recommendations for me as far as time frame, looking at trends. Should I be looking more like in a year's time, or it's just been difficult to focus, you know?
Yes, and I can understand that. That's one of our challenges in infection prevention. I would encourage minimally that you're running the TAP report quarterly.
Okay. All right.
But if you are specifically implementing an improvement effort on a unit, I would actually then be running it like a month after implementation to see if there was indeed impact. And so that could have been what was going on with your report, is actually what you were doing or talking or implementing was having an impact on your top units, or it may have been a fluke.
Right.
The other component is if you're seeing a lot of variability between the different units, it's a good time to go and talk to those frontline staff. Was there something going on that was unique during that month? Especially when something jumps up and it's never been a problem before, you might find that you actually had system problems with products coming in and they had to do a product substitution that you weren't aware of, or because of a new system or something going on electronically within the computer system, they're having harder times to document things. Again, the best way to get there is actually, to get out of our offices, and I know it's really hard because we're really data-driven and we tend to be at our computers working those infections up, but it may be time to come out of the office and actually talk to staff and find out what potentially was going on during those time periods.
Right. All right, thank you so much.
You are welcome.
And we have no questions at the time.
Thank you, Adrian. Well, I think at this point in time, I'm going to have Jennifer, could you release the evaluation for today's webinar? This will conclude today's educational session. Remember that the PowerPoint presentation is a WebEx handout, and under that original email that you received with the link, you can always go right back in there, and you'll see on your left-hand side where it actually says event materials. If you put the word TAP, T-A-P, capital letters in there, it will bring up the PowerPoint presentation, as well as you can use the link that Kim shared earlier within the TAP section. The recording will be available in about 2 weeks, and using that same website, the LSQN, then going to the HAI, in the right-hand corner, you'll see a recording list or a playlist. You can click on that. If you go to the Healthcare Associated Infections tab, you should see it printed there. And as leads, we tend to send you a link once we do have those posted so that you'll be able to access that also. We do encourage you to please take a moment to complete today's evaluation because your feedback is very valuable to us because we want to make these events to be as quality packed as possible. But I do want to extend from the entire team that thank you for spending time with us today.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating, and you may now disconnect.